Okay, I think that we are live, everybody. Hey there. Good morning. Today is Taste Life Nutrition Radio and Podcast. I'm Nikki Burnett. Always working through the tech issues, right? Anyway, we were supposed to have a guest today, and she had an emergency, unfortunately. So it is me totally winging it. But the show goes on. We're going to have some fun with it. Today, we were going to talk about inflammation anyway. And so my thought was, well, let's just talk about inflammation. Make sure I get everything going the way it's supposed to go here. We're going to talk about inflammation, but we're going to talk about it specifically as it relates to cardiovascular health. I think it's a big topic. I think it's a super misunderstood topic. And it's one that we haven't talked about in a while, not in any detail. And so I think it's something that is a great way for us to start today. So that's what we're going to do. So, first and foremost, we always start the show with gratitude. I'm super grateful for a nice long holiday weekend. We were supposed to do some camping. Unfortunately, we've got a ton of fires here in Colorado, and it's a tough time for a lot of people. So we have our prayers for going out to those who are struggling with the fires, and prayers to those who are out there fighting the fires. Hopefully those are under control very soon with very little damage. I know it's been tough on a lot of people. So, but grateful for the opportunity to have a long weekend for 250 years. This country has been around. How freaking cool is that? I don't really care where you are, what side of the fence you're on. We live in a pretty cool place with a lot of opportunity, and so amazing that we're still so young, but we've been around for 250 years. So that's certainly something to be grateful for, and grateful for God's hand on us. It's good stuff. So. Welcome to Taste Life Nutrition Radio and Podcast. And I'm Nikki Burnett. As you know, I'm so glad you're here. This show here believes in really one powerful truth, and that is that health is not the goal. I don't want to look at health as the goal. A lot of times we're looking at health and we're looking at it from sort of from behind or from something. We're trying to avoid something in order to, our health is to avoid something. We don't want to have what our parents struggled with. We don't want to struggle with what our friends and family struggle with, right? Instead, health is what gives us the capacity to fully live. So what is the opportunity when we have health? And so when we build our health, we build our capacity to love well, to lead well, to serve well, and to fully live the life that God has entrusted us with. It's really cool stuff. And so that's really why this show exists. Each week we're going to explore all the different topics, right? I mean, we've been around for 6 years. You know what we're about. So we're talking about longevity, epigenetics, leadership, faith, the latest science, the cutting edge science, all the cool things, right? It's not simply to help you avoid disease, but really to help you better understand your body and to build the health that allows you to fully taste life. So because your body was created with this remarkable intelligence, right? It's always adapting, it's always communicating. And your future isn't fixed. That's the cool thing, right? That's the beauty of epigenetics. And so your genes are not your destiny and your choices matter. And so the goal with every episode is to hopefully leave you with one practical step that you can take to better understand your body, steward your health well, and create a healthy future. And so I'm so glad you're here. Let's taste the life. So, all right, we're going to dig into heart health and cardiovascular health. I want to dig into the labs. I did a training on labs. I don't know if it's training. So I've started doing, so it's a little bit of a, what do you call it? Anyway, just I want to tell you about what I'm doing. which is a new conversation. It's a new workshop, whatever you want to call it, right? So we're doing what's called the ripple effect. We had our first one yesterday. We had a great turnout. It was super fun. Lots of discussion going on in the chat, right? Lots of great questions, which is the goal of it in the first place. And so it was specifically over labs. It's called the ripple effect. This is our free monthly health intelligence conversation that we're doing for anyone who wants to join. And so we had people from all over the country who joined yesterday. So much fun. And so the goal is to talk for, well, my thought was we were going to talk for, about an hour or 45 minutes and then answer questions. Well, the great thing is it became a conversation, right? We're having this conversation through the chat, and I'm answering questions that a lot of people are going to have questions about. So really enjoyed it. So it's in my membership platform. The recording is. So if it's something that you want to view, then you need to be in the membership platform, which we're still building out. So there's no cost to it. If it's something that you want to join in on, I'll link it. Where will I link it? I'll link it in my bio, and I'll link it in all the comments and that kind of stuff. I'll put the link in there so you can join and join in on the conversation. It's brand new, right? We're just building it out. We don't have a whole lot of people in it yet, but that's what happens when we're first starting out. So the point to all of that is we were talking about labs, and there's so many things that we don't understand, that we aren't told about our labs. So often we're told your labs are fine when we don't really feel well and don't feel like our labs are fine. There's a lot deeper information in labs than often we're told about. And so one of the things, kind of the basic thing that I want to make sure that we have an understanding of is that when we're looking at labs, we have our conventional ranges. And conventional ranges they can vary from lab to lab, but they're basically the ranges that we've been told are the ranges that we need to be at. And it's for the general population. It's not for the optimized general population. These are based off of sick people, right? Or less than optimized. So we don't, excuse me, we don't want to just look at lab ranges for most of these labs. We want to look at them from a functional perspective. And what that means, yes, the term functional medicine, functional nutrition, that is, sort of the cool fad term for what we do now. But it truly is optimal functioning of the body. And that's what functional ranges mean. That's what they mean to me, is how is our body functioning and is it optimal? And are the ranges we're looking at optimal for me, for you, right? And so those ranges can vary a little bit they'll vary based on looking at it from a functional perspective, but it might also vary for you, right? Just because you have some liver markers, and this is a really good example. It's kind of outside of, well, it's not, but anyway, this is a good example of if we are looking only at a number and our liver markers are elevated, so our ALT, our GGT, our AST, if those markers are elevated, we might have a little bit of concern about it, right? Even if whether they're out of lab range or functional range. But if you're somebody who works out really hard and regularly, they might be elevated anyway, right? So I did my labs back it's probably last quarter. So I'm about to do my next set. So I've been doing it once a quarter to, check my own markers, and, I'm making some changes. So I want to run my labs and I want to understand my data, right? And my AST and ALT were elevated. And so I have that automatic, oh, what's going on? Why is this happening? Is this a problem? Well, no, I do CrossFit. I do it regularly. I work out hard. I lift really heavy. So I would expect that my ALT and AST would be a little bit elevated, and I'm not concerned about it, right? Now, if I was a heavy drinker or I ate a lot of really sugary food and that kind of thing, I might be more inclined to think, okay, this could be an issue, and I want to have some liver support. And I think we need to have liver support anyway. I think it's a smart thing to do on a regular basis. But I think that we want to look at labs in context. I think that's the important takeaway here, is look at them in context. So all of that being said, understanding that we're looking at these panels from a functional perspective. It also, though, it opens up the amount of labs that we want to run. And so oftentimes when we're looking at um, going to our primary care provider, right? And they want to run a comprehensive metabolic panel, a CMP, and a CBC. And so they'll do that. And what we get back is a pretty limited view of what a comprehensive metabolic panel is. I think CBCs tend to kind of be pretty much the same, but the CMP, it can be a few markers too. In my world and the ones that I run, they're big panels, really big panels. But the more panels, or the more markers we run, the more information we get, and the more we're able to put pieces of the puzzle together so we have a better understanding of our body, and we're not sitting there guessing, going, what's going on. And so when it comes to lipid markers specifically, usually lipid markers are part of a comprehensive metabolic panel. But it's usually really limited. But we're told, right? We're told that we need to look at total cholesterol, LDL, HDL, and triglycerides. Usually that's it. Sometimes they'll throw in VLDL. Every now and then they'll throw an inflammatory marker called CRP. These are markers that I'm going to run on everyone all the time. Now, what I'm also going to do, though, and I can't do it through a CMP. I mean, I guess I could. It just makes it a little more difficult. So when I'm running, I have a specific heart health panel that I will run on people, on anybody I can, right? I'm going to run it on anybody who's going to allow me to, because this is the data that we need. Heart disease is, what is it, the number 2 killer right now? And so why is that? How can we not want to get as much information about our cardiovascular health as possible, so we can start to mitigate any of the risk factors that we might have? And we can do that, right? I mean, when we have, knowledge is power. I say it all the time. Knowledge is power. And even if we were to also layer in our genetics, huge in helping us understand how we need to eat, how we need to live, the toxins that we need to eliminate in our world and in our diet and in our homes, right? All of these things play a role in cardiovascular health. Cardiovascular health is an inflammatory, cardiovascular disease is an inflammatory disease, but it is a lifestyle inflammatory disease. And so when we know what's going on and we know what's going to be the most beneficial for us, then we can take it, we can mitigate that risk, and we don't have to, we worry less about what's actually, this actually becoming a problem and expressing in our life, right? So let's see, I've got a few of my notes here. So a couple of things to note. Heart health is shaped by multiple things, right? I talked about inflammation, but what is it that's pushing the inflammation? That's the stuff that we need to really understand, because inflammation doesn't happen just because it's going to happen, right? We don't get disease just because we're going to get a disease. There's an inflammatory process because the body is trying to manage whatever is going on that's pushing that inflammation. So heart health is shaped by blood sugar, by insulin resistance, by inflammation, obviously, both of those things pushing inflammation, blood pressure, smoking. Yeah. It just amazes me. We still see people smoke. Just one of the worst things that we can do. Sleep, stress, family history, physical activity, kidney health, and the number and type of cholesterol carrying particles moving through the bloodstream. And we're going to talk more about that and get really deep into that, because the particle sizes are so important. They're huge. And those aren't part of a comprehensive metabolic panel. This is stuff that we've got to know. Okay. So we don't want to, this is not, a fear-based conversation. This is really an empowering let's get the information to you so you can understand your labs, right? And knowing that the labs are clues. It's I always talk about the body communicating with us, the body talking to us. It's always talking to us. Mine's talking to me right now because I'm hungry. I didn't get to eat before the show, so I'm listening to it. I'm like, okay, I'm gonna eat as soon as this is over. Go sit out in the sun for a little bit. But so we want to excuse me. We want to make sure that I had a point that I was going to say, and I just totally lost it. Oh, the body's talking to us. That's what it was. So when we're listening to what the body's telling us, and we start to understand the language of the body, and what I believe to be the case is that labs just deepen that understanding. It deepens that language. So we can take our lab work, and so we look at the results of the lab work, and we layer it in with symptoms, with goals, with needs, with history, with all of this stuff, with genetics, hopefully, maybe with other labs. And the more data and the more information we have, the more we understand what the body's trying to tell us, who we are through and through, and how we can create this amazing life and build on this amazing life that God gave us, right? And so, when we feel good and we're optimal and we're not living out of fear, right? If we have a history of cardiovascular disease in our family and we don't understand our own risk, that's just going to sit there and it sits in the tissues, and it's more fear than the empowered I have, and I know who I am and what my body needs and what it's doing and how to mitigate the risk. And so that is how we want to change the narrative from the fear. I want health because I'm fearful of what has happened in my history or in my family history, to I know me and I know how to create health, and I know how to move through creating better health. So we are moving forward in a positive, what is optimal, right? How can I be my optimal self based on what I know about myself? Okay, so I'll get off of that soapbox, but I just think it's so important that we really switch that, flip that narrative from the fear of what could be to what's the potential, right? What is our potential? What does health mean for us? Does it mean that we have better conversations? Does it mean we climb more mountains? Does it mean we play with our kids? Does it mean we feel good in our skin, right? This is how we flip health, the narrative of health. And that's the same with cardiovascular health, right? And so let's see, let's move on to, I like this. I like this. I like having this understanding about inflammation because we don't always know that inflammation is happening. And that's where labs can really come in to help us, because inflammation is not always loud, right? We don't realize that maybe there's this, I always see like this chronic underlying sort of low-lying inflammation. I see it as like a little grass fire, right? It's there, it's hot, it's smoking. Is it creating a lot of damage? Well, it's creating a lot of damage to some of the stuff, right? This burning the grass. It may not be burning the trees yet, but it's sitting there just kind of smoking and lingering. And so we got to go at it. We still got to fight it, right? And so that's what the body does when we have this this little chronic inflammatory process that's going on, and the body's just trying to manage it. And it's not okay, because then the body's focused on that and that's not focusing on all of this other stuff. And it's taking all of its resources to try to manage this little chronic, itch that's going on that's really annoying to the body. And so it uses nutrients and it uses resources. And so we may not realize it's there, but in time, it's going to start telling us, right? I always look at it like, the body's symptoms over time, it's just going to start knocking. The knock is going to get louder and louder and louder. And so what does that mean? Well, it looks like pain. It looks like inflammation. It looks like brain fog. It looks like the cascade of disease and cardiovascular disease. And so we want to, when we understand our labs early on, this is why running these labs are so important. When we run these labs early on, even if we don't realize that there is anything going on, or maybe there's not anything going on, but we then know how to optimize And we can see if there is that inflammation that's sort of lingering and sitting there. We can go, okay, there's something going on. Let's figure out what this is. And then we put our history in there, like, okay, now I know how to manage the inflammation and manage my risk. So inflammation is an important part of who we are. We have to have that inflammatory cascade that happens. But it's when it becomes, I think I kind of said this a little while ago, but it's that chronic inflammatory cascade that becomes the real problem. And so we can look at things like CRP. So if we're looking at our labs, CRP, unfortunately, is usually only done by our cardiologist, right? In my world, I want to run a CRP on everyone. Yes, it's a cardiovascular marker, but it's a global systemic inflammatory marker. And so we want to understand if our CRP is elevated. And I see it elevated all the time. Hey, Debbie, I'm sure you see it elevated all the time too. So, CRP, we want to, when we see that, and there are other inflammatory markers, right? We're going to get into them. But CRP is one that we want it as close to zero as possible. What it shows out of lab range, it shows that over 3 is out of lab range. In my world, if it's over 1, I'm like, what's going on? Right. And it doesn't seem like it's a wide range, but if I'm starting to see it creep up and it's sitting 1, I'm like, okay, what's happening? Is there something going on? And then it can just go creep and creep and creep and get higher and higher if it's not something that we're aware of. So when we're looking at a marker like CRP, though, we're looking at it in a pattern, right? We want to see it's not it's an inflammatory marker, but why? So it doesn't give us information except there's some inflammation going on, and we want to make sure that we figure out why behind it. I mean, it can be elevated with people who have chronic autoimmune disease. It can be elevated with chronic GI issues, right? I had a client back. It's been quite a while now, but her main complaint was severe depression, right? So she was on the drugs. We were trying to figure out how we can manage it without her, and with her, of course, with her provider, but how we can get her off of the drugs. And I'm going to tell you that was her only issue. That's all she was seeing me for. And her CRP was I think it was at 18. It can go higher than that. It certainly has gone higher than that, but that's really high. And in my world, it just kind of freaks me out a little bit. So that was our main goal. So, depression, anxiety, these are symptoms. We don't just get depressed to get depressed, right? There's an inflammatory cascade going on behind it, and we've got to figure out why. And so that was our main goal with her, was get that inflammation down. And hopefully that in time would help to balance out some of the stuff that she had going on. So really important to know. And obviously she was not a cardiovascular client of mine, but certainly could impact her cardiovascular health had we not known that marker was that high. So let's see. Yeah, okay, so other things that can push CRP is going to be, was I sick recently? Have you had some dental work done, or is there inflammation going on, right? We know this about our mouth at this point. By this time, the health of our mouth, the health of our oral microbiome plays a huge role in our systemic health. And, so we want to make sure that we are, are you oil pulling? I'll tell you, I oil pull every day, almost every day, with antimicrobials and with colloidal silver and with some essential oils and peppermint, and then coconut oil. So I do that on a regular basis. And so, that's my way of controlling my oral microbiome and I also do probiotics for my oral microbiome. So I'm managing anything that shouldn't be there and building up what should be there. Let's see. Am I sleeping poorly, overtraining, or under recovering? That can push CRP. Blood sugar instability can push CRP. And then other, of course, inflammatory conditions can certainly see it. I mean, I see it in, Crohn's disease and ulcerative colitis and that kind of thing. So Let's see, another marker we can look at is fibrinogen. I rarely see that. If somebody comes to me and brings me their CMP, I rarely see it, fibrinogen, and it's a shame because it's a measure of blood stickiness. So if we're thinking of putting some of these, we start putting things together, right? So we think about maybe we don't realize that there's a cardiovascular risk, but we are struggling with blood sugar issues, and so we want to, if we're looking at understanding blood sugar and how we want to mitigate our risk with insulin resistance and diabetes and that kind of thing, what are the other markers we want to bring in? Well, we certainly want to bring in cardiovascular markers because it's a metabolic issue, right? And so, but we also want to look at fibrinogen. So if our blood is too sticky, which is what's going to happen with elevated blood sugar, we need to understand that, right? So it's influenced by smoking, inflammation, infection, pregnancy, right? So know that there are certain reasons why it can be elevated. Metabolic dysfunction, and then of course other types of stressors. So let's see, moving on, homocysteine. This is another big one, so big. And again, so I had a young client, she was in her 20s, early 20s, and I wanted to run a CMP on her. And what I'll try to do with my clients is, if they have insurance and I can get a lab like this run through their insurance, it's just going to save them money, right? Because most of the testing I do is not run through insurance. It's going to be, it's cash. It's just the way that it is. It gives us a ton of information, but so does the CMP. If we have a good big CMP, homocysteine is always included on my comprehensive metabolic panel, always. So though, often what will happen, which is a real shame, it's really frustrating, is a doctor will look at the list that I've sent to this client for the client to give to the doctor. And I'm going to tell you, if this has happened to you, I need for you to advocate for yourself. If you have a list of labs that you want run because they're your labs in your body, you need to advocate for yourself. It's really frustrating for me when a doctor's like, no, you don't need a homocysteine because you're too young. It's trash. It's total trash. Homocysteine can be elevated for a number of reasons. One is nutrient deficiencies. So just because you're in your early 20s doesn't mean that you might not have nutrient deficiencies. Most everybody does. This is why we're working with people all the time, is to manage their nutrient deficiencies. If we had robust nutrients in our body, a lot of these things wouldn't be happening. Right? This is why so much of this stuff is lifestyle based. Now, I'm sort of going on a roundabout way of this real quick, but the thing that also we need to keep in mind is toxins also use up nutrients. So we may be eating perfectly, but things that are going on in the body and the toxins in our environment and our exposures and stuff, those can really go through the nutrients as well. So again, going back to, it's really important to do your labs and understand your toxic load and that kind of thing. So you know what nutrients are, well, when we can do a micronutrient panel, but we can see what nutrients are being used up, so we can address that. Now back to homocysteine, it's a lot of times a nutrient deficiency. There are a couple of B vitamins, there's trimethylglycine, there's magnesium, right? So there are a few of these things that can come together that can play a role in homocysteine being elevated. Homocysteine is an amino acid, and it's part of our methylation pathway. So our methylation pathways, and there are multiple enzymes involved in that pathway. So it's not just one. So this is another great reason why we would want to know our genetics, is because we can look at these pathways, we can look at these enzymes and see what our genetic potential is for some of these pathways to function less optimally, right? So anyway, in this pathway, if there's an enzyme or multiple enzymes that don't function properly, what can happen is homocysteine is supposed to go down this pathway, and if it doesn't, it gets stuck, right? And it goes up and up and up and up. And so going back to lab values, and like I said earlier, they can change sometimes from lab to lab, which is really annoying. But I believe that the lab value, it's 12 to 13, but functional range is 7. You don't want to go below 6. And if I start seeing 8 and 9, I'm starting to question what's going on, because according to Dr. Dale Bredesen, who is the guy who's reversing Alzheimer's disease, right? Which there's a lot of factors that go into that. But anything over 11 is 100% chance of cognitive decline. And so until I'm told differently from somebody smarter than Dale Bredesen, which, you know, he's a pretty smart dude, if I start seeing it creep up to 8, 9, 10, I'm like, okay, what's happening? Is it a nutrient deficiency? Do we need to look at your methylation pathways? Do we need to look at your food? But also it can be elevated due to oxidative stress. So that's another thing that we can measure. If you want to, we can look at your oxidative stress. We can look at your genetics that can push the potential for greater oxidative stress. And so we can also, I think, let's see if I get this right. I believe low creatine can also push homocysteine. There is a SNP that can inhibit the production of creatine, which there are those who've been diagnosed with like chronic pain, chronic fatigue, and if they check that variant and see that variant is not functioning properly and add in creatine, then that creatine can help with the muscle pain, right? And creatine is amazing anyway. I take creatine every day. Most people, they say take, and again, little side note, but I think it's an important one. Take 5 grams of creatine if just for working out. More and more, you're taking it. If we're taking it, and this is why I take it. I mean, I take it for, you know, because I work out and it, you know, helps me. You can see my muscles when I take creatine. It's really cool stuff, right? But if you're taking 10 grams, and now I think that the data is even showing, I mean, I know it's showing even 20 grams a day. I do 10 in the morning and 10 in the evening. It's better for cognitive health. And for me, I know my genetics, I know my risk factors. That is my biggest concern. But it's not a concern, right? This is the thing I focus on the most, because I know my genetics, is my cognitive health. I also know my family history, so I want to pay attention to my family history and be aware of it, and then know my genetics and make sure I'm paying attention to my labs, so I can keep everything in line and know that I'm doing the right things. And when something is not in where I want it to be, how do we veer, right? This is how we know how to veer, and again, you know, fully optimize. So let's see a couple of things here. Oh, I have you know, like I said, I sort of made my really quickie notes since we had to quickly change the show up today. So homocysteine can be influenced by, so I said some nutrients, and so these are the B vitamins that we were talking about. So B12, folate, B6, riboflavin, kidney function, thyroid function, genetics, inflammation, lifestyle factors, right? So there's a lot that goes into homocysteine. Generally speaking, it's pretty easy to pull down, right? You know, I've had a couple of clients whose homocysteine was sitting up at 18. I'm like, okay, that's a big enough deal. We need to let's look at your oxidative stress. Let's look at your lifestyle. Let's bring in. I have my favorite supplement that I think is really, really great for lowering homocysteine, and so we'll put people on that. So I'll just tell you what it is. I think it's important. So my favorite, there are several, but my favorite is Apex Energetics. It's their Super Methyl SP. I use it for myself. I don't generally have elevated homocysteine, but I do have some methylation issues. And so my methylation can go low, and it really helps with that. Interestingly, when my methylation goes low, I lose hair right here. So it's sort of my telltale that I need to make sure that I'm getting my my super methyl SP. Okay, so another thing about homocysteine that I think is important to understand is, yes, it's an inflammatory marker. It's a cardiovascular risk marker. It's a cognitive risk marker, right? And so I hit that on that a little bit, but I want to make sure you take that home with you, because so often it's not tested, and so often we're only looking at it as you know, the cardiologist, like, okay, let's run your homocysteine, but we're not looking at it as a risk factor for our cognitive health. So keep that in mind. All right. So let's look at particle sizes. This is the stuff that is really cool too, because when we're looking at HDL and LDL, what we're told is that HDL is good and LDL is bad. And it might be one of the most frustrating things that I hear on a regular basis from conventional medicine, because it's such a simplistic and uninformed way of looking at cholesterol and the need for cholesterol and what cholesterol means and what cholesterol does and the necessity of it. LDL is a necessity to our life, into our body, into the way that it functions, into our brain health, into producing hormones and cellular integrity, right? We have to have LDL. And to sit there and go, oh, your LDL is too high, we need to put you on a statin so we can lower it as low as we can possibly get it. It's a terrible way of looking at the body. And, you know, I'm not the smartest person in the world, for sure. And those in the medical community oftentimes have a lot more education than I do, but I feel like there are a lot of blinders that are put on when it comes to true health and asking questions and understanding biochemistry, because HDL and LDL are both necessary. LDL brings cholesterol to the tissues. LDL is just a carrier protein, right? It brings cholesterol to the tissues. HDL is what brings it to the tissues to be utilized, where we have to have it, where again, we have to have it for brain function and muscle function and cellular integrity and hormone production, right? If you don't have LDL bringing cholesterol to the tissues and creating hormones, what's going to happen? Right? Our hormones are going to go super wonky, right? Testosterone's going to drop, estrogen's going to drop, things get way out of whack. And we wonder why men who are on statins end up in andropause. Breaks my heart. It just breaks my heart. So LDL is absolutely necessary. HDL though then comes in and it picks up the cholesterol in order to be either recirculated, reused, or eliminated. So that's why they call it the good, because they're taking cholesterol away. But we got to have cholesterol, so let's not forget that piece. Now, what's super important about understanding cholesterol is that cholesterol in an inflamed state is where it becomes problematic. So we have cholesterol they're considered big buoyant particles, right? So I always see them, you know, in my mind, I imagine, I see pictures, right? It's what helps me understand things, I guess. But I'm always envisioning these big buoyant fluffy particles just kind of running around, you know, the body doing its job, and you know, it's fat and happy. Right? So then though, when a person is inflamed, right? So if we're looking at CRP, if we're looking at homocysteine, there are multiple other inflammatory markers that we can look at. Just because CRP isn't elevated, to back up a minute, doesn't mean that there aren't other inflammatory markers. So it's important to really have good understanding of what's going on in the body. But if we're in an inflamed state, there are a couple of markers that we can look at. And there are multiple, but one is OX-LDL, which is oxidized LDL. The other one is SD-LDL, which is small, dense LDL. And so I put those on a panel. So if I see in a panel that LDL is elevated, the next thing I'm going to do is I'm going to go look at inflammation, and I'm going to go look at these other two markers. Okay. And so what happens, I mean, it's just like it sounds, right? So we're inflamed, and these particles end up oxidizing, and then they get really small. So instead of being big and buoyant, they get really small and tight and dense and oxidized. And so that's problematic. That's problematic because when we're inflamed also, see how deep I can get into this, but we're inflamed, the body has the potential of the zonulin. So we talk about zonulin when it comes to gut health, but zonulin's everywhere. So zonulin's elevated, it pulls cells apart, right? So it'll pull cells apart in the gut. This is leaky gut. It'll pull cells apart in the brain. We've got leaky brain. It'll pull cells apart in the vasculature, right? And so you've got leaky cardiovascular system. And that's when things start to go haywire, right? So if we have cells that are coming apart, that's when we have this cascade of the body going, oh, something's happening. I've got a big problem here. I need to go take this calcium and all of these other components, and I need to put something in this place. So we're not, so there's not a bunch of stuff getting in the body that's not supposed to get there. So it wants to go and scab it all up for us, right? So the body's doing its job. The body's always doing its job. It's doing exactly what it's supposed to do, and it's going to do it with all of the resources that it has. And so even if we feel like something's gone dysfunctional, is it truly dysfunctional, or is it that the bodies keep trying to keep us alive, right? And that's what I see always. I see the body's one ultimate goal is to keep us alive. And so what we need to do is partner with our body and go, okay, I'm listening to what you're saying. I'm better learning learning the language that you have. I've got the labs in front of me. I have my genetics, and I'm like, okay, now I know how to better partner and give my body what it needs. So super cool stuff, right? There's another marker called ApoB, which is let's see. Oh, it's giving me a bunch of illustrations. I think I'm not going to worry about that, but essentially we want to make sure that ApoB is not elevated. It's a pretty intense cardiovascular risk marker, and so we can look at there's ApoA1, which is a beneficial marker, ApoAB, ApoA1, ApoB, and then there's a ratio. And so you want to, that ratio needs to be in line, and then you want to have your ApoB. I can't remember exactly what it does. I should know. Do I have it here? Not a big deal. I just want, just make sure it's not elevated. It's how many delivery vehicles are on the road. Oh, so so basically how many of the particles are circulating? I think that's what it is. And so we don't want to have these circulating oxidized and small dense particles. So making sure your ApoB is in line. So then moving on to a huge marker. This is so important. And I want to, I say that about all of them, but they're all important. But this one is a difficult marker. So it's called Lp(a). And the reason it's so difficult is because it's really a hereditary marker, which makes lifestyle is less, your lifestyle modifications make less impact on Lp(a). And so what I believe to be the case is when we have I have a couple of clients, a father and a son, right? The father's mom died suddenly from her first heart attack, right? It was just a one and done and out. What I believe to be the case is she likely had this Lp(a) marker. So it's that big a deal. We need to know that we have it because we can get it down, right? If you look for Dr. Steven Sinatra, he's a cardiovascular, he's a functional cardiologist. Words sometimes are hard. Functional cardiologist. And so I did a ton of research from him, from his books, and from multiple. This is what I did my thesis on, essentially. Anyway, he's super amazing. He'll give you a lot of really great information if these are things that you want to look into, need to look into. And when I'm working with my clients and patients, that's the first book that I will give to people. I'm like, don't listen to me, do your own research, but get this book, right? So Lp(a) can come down. It's just harder. But we need to know if it's elevated. We need to know our potential. We need to know that we have it so we can track it all the time, every year. If it's ever been elevated, you got to try to get it down, and then you've got to track it all the time to make sure it's staying down. And I've watched it come down. We can get it down. It's slow, but we can get it down. So I have this this family where we are just in the middle of their testing because both of their LP little A's were sky high. And I'm like, guys, you've got to do something about this. We've got to clean up your lifestyle. We've got to do these supplements. We've really got to get moving on this because it's a scary place to be. So know you have it. And I also have people going, I don't want to know the risk factors. I don't want to know if I have something like this. It doesn't help to stay in the dark. It's not a good place to be in the dark. I say it all the time, knowledge is power, because then you can mitigate risk. So get it done. Everybody should have it done. Anytime I run it on everyone. We just need to know. So anything else on that? I think that's it. I think that, yeah, let's move into blood sugar. I think blood sugar is an important, well, we hit on it just a little while ago, but we can't, I mean, the body is connected, is all connected, right? And so we can't separate, oh, I have elevated blood sugar and think that's not a cardiovascular risk, because it is. So they're very, very connected. And so what can happen is when the body becomes less responsive to insulin, then we need to produce more insulin to keep glucose in the normal range. So it becomes at this point where we become pre-diabetic. I think it's important also, though, sorry, I'm reading my notes, to speak to women for a minute on this as well, because when we're looking at labs and we're only looking at lab values without having context, especially those of us who are, and specifically those of us who our hormones are changing, we don't want to just look at a marker and say, oh my gosh, what's happening? Because what happens then is our hormones are changing or, kind of diminishing, right? And what can happen is we can have lipid markers go up and we can have glucose go up. And we're like, nothing's changed. Everything's the same. I'm eating the same. I'm eating perfectly. I'm working out, but these numbers are going up. It happened to me, right? This is why I'm testing myself all the time, because I want to make sure that I'm doing all the things that I can, but I'm doing it in context, right? So I'm no longer cycling. My lipids went up, my glucose went up. I'm like, what's going on, right? So that's going to happen when we don't have the protective hormones, specifically estrogen. Testosterone is also protective, but estrogen is so important. It does so many things besides just, women's things, right? It protects our heart, it protects our brain. If it starts to go down, it has the potential, I think a big potential of impacting lipids and glucose. So what I don't want you to do as a woman is just freak out. And what I meant to say a little while ago was what happens in conventional medicine is it stays separate. We never bring in the fact that our estrogen is dropping, is not part of the conversation. And what we're told is, okay, now we need you on a statin and we need you on metformin. And that becomes problematic. And this is fear-based, right? That's what we're trying to get away from. Let's get away from being fearful of what could be and have true understanding as deep as we possibly can, have our team of people who we trust who can help us to understand these things and say, okay, I have the power. Now I know what I need to do, and I don't need to bring in statins and metformin. Now, everybody's different. You make your own decisions on what you need to do. For me personally, I would never, ever, ever, ever put myself or anybody I love on statins or metformin, especially statins. Metformin is just kind of a dirty drug. It's an old drug, been around a long time, but statins are they're so horrible. According to Dr. Sinatra, the last I read, data changes all the time. Could this have changed for him? Potentially. But last I read, according to Dr. Sinatra, the only people who really should ever be put on a statin are men who have already had an event, right? So that's not coming from me. That's coming from Dr. Sinatra. Go read his book. His book is so good. It will give you so much data. And I want you to have good tools in your toolbox so you can make good decisions. That's all I care about. It's all I care about when I'm working with people. It's all I care about with this show. You're going to make your decisions that are best for you. But I want you to have as much of the knowledge as possible so you can make the decisions based on good information, right? Okay. So let's see. Um, yeah, we don't want to only look at glucose. It's only part of the story. So we can have, we want to look at A1C, certainly. Some will say A1C is like a 3-month look at our glucose levels. I think it's really more like a 6-week look. Also, I said this yesterday. Oh my gosh, we're so close to being finished with this. Anyway, but one of the things that I hear with my older patients, they're in their 60s and their 70s, they're told, I mean, I've heard this multiple times. They are told that if their A1C is over 6, that it's okay because they're older. I think that's a real problem. And I think it's setting people up for conditions that don't have to express because they're given an excuse. And I think that's a real problem. I think it still needs to be down as low, not as low as possible, but that 5.2, 5.4, 5.6, right? Keeping it down there. I don't care what your age is. I think it's a problem if it's higher. So we also will look at triglycerides, HDL, obviously waist circumference, blood pressure, liver enzymes, family history. Let's see. I know we're starting to run a little bit short on time, but I do want to hit on GGT. GGT it's a marker that I don't see run all the time. I try to run it pretty regularly, but I don't see it run a lot. And so one of the things that's important to it is it gives us a lot of context around oxidative stress. But it also helps us understand like alcohol exposure, medication burden, bile flow, and metabolic strain. But it's the oxidative stress one that really sort of piqued my interest when I learned this because, sorry, because it also helps us understand glutathione. And so glutathiones are master antioxidant. And so if we know where our GGT is, it is an indicator of where our glutathione is. And so if we are, we can have genetic variants that don't allow us to utilize or to produce glutathione the way that we should. It's important for oxidative stress. It's important for recycling other antioxidants. It's really, really important. And so it's part of detoxification, right? So we want to know that our glutathione, we have enough of it and it's doing the job that it needs to do, right? And so if our GGT is elevated, we can kind of go, okay, I mean, we can, look at our genetics and that kind of thing. But if we're just doing this on a CMP, it's one of those little red flags that can help us say, okay, I need to do some liver support. I need to look at my environment. I need to look at what's going on. I might need to look at EMF exposures. What do I need to do? And I might need to bring in glutathione or N-acetylcysteine into my world so I can manage whatever's going on, this oxidative stress that's going on. Okay. So it's not a direct correlation, but it's a pretty cool little nugget that is, I think, a good thing to understand and to look at. So let's see, I got just a couple more minutes. Let me see if there's something else here I want to, well, we did pretty good actually. So I think probably the biggest takeaway is is when you take your labs, especially when it comes to cardiovascular health, and you have a deeper understanding or know that there's more. And when you're told either you're fine or you're told your numbers are in range or you're told that you need a statin and that's only based on your LDL's too high, all I care about is that you have the ability to ask questions. Ask questions and always ask why. That's huge. Always ask why. Get curious, have a better understanding of your body, and find your team of people who are going to support you in the choices that you make. That's so key to all of this that we're doing. So, okay. And then lifestyle, it just plays a role in everything that we do. Obviously, I mean, it's like the thing. So are you, managing your sleep? Are you, reducing alcohol? I had a question yesterday in the workshop is, should I stop drinking? I'm like, alcohol doesn't really do us any favors, right? I mean, is it the worst thing in the world? For some people, yeah. For others, having a little bit of, a little bit here and there is not the worst thing in the world. But, my goal and what I want for myself and for my family and for anybody I come in contact with is that I want you to have in your life all of the best things, and nutrient density is one of those things. I want you to eat foods that are going to benefit you. I want you to drink water and drink things that are going to benefit you. Alcohol, there's just no benefit. There really isn't. I had a glass of wine last night. So, it's part of life. But there's no benefit to it. So keep that in mind. It's inflammatory. It's problematic. It's hard on the liver. So it's best not to do it. I tell myself that every time I have a glass of wine. Okay. So, in closing, what I want is for you to remember that the body is created with such amazing intelligence, right? It's always adapting. It's always communicating. Let's listen to what it's saying. And it's always being responsive to the life that you live. And so each choice that you make is literally shaping your future. And so it's not about, perfection, but it is through these small intentional steps that we take consistently over time. So this week, what I hope is that you remain curious, so that you listen to your body and that you steward it well, and that you take one intentional step. Is it something that you learned from this show today, or that you learned from somebody else, and toward building the health that gives you the capacity to live fully the life that God has entrusted to you and to me. I mean, I do the same thing every week or every day, right? I try to do it every day. Anyway, because health isn't the goal. Remember, we don't want to live in fear. We don't want to have health because we don't want something. We want to have it because it truly gives us the capacity to fully live. So until next time, keep building the health that allows you to fully taste life, and take care. God bless, and we'll see you next week, Thursday, 10 a.m. Mountain Time, streaming live on KUHS Denver. This is Taste Life Nutrition Radio and Podcast. You'll find us on all the podcast platforms loaded up next week. If you have questions, always you can find us, Taste Life Nutrition, in all the places and all the social media. And remember the ripple effect. So the ripple effect is our monthly health intelligence conversation. The first Wednesday of every month. We did one yesterday, and we'll have the next one coming up August 5th. So that's at noon Mountain Time, every first Wednesday of the month. So if there's anything that I can do to be of service to you, please reach out, and we'll see you next week. Bye, y'all. Thanks for being here.